looking so beautiful, so we don't want to be distracted today. So kindly switch off your videos and mics, and please post any questions that you would like in the chat box, and I will put forward the questions to Dr. Sangita at the end of the session. So without further ado, I would like to pass the session over to Dr. Sangita.
Thanks, Anna. Can you hear me? Am I loud and clear?
Yes, loud and clear.
Okay, great. So thank you for having me today. It's a great honor speaking to pediatric dentists and the fraternity. It's very interesting when Anna told me to prepare this lecture, and I spoke to a few of my fellow neurology colleagues, and I asked them, have any of y'all spoken to pediatric dentists? And they were all like, no, no, no. And I'm like, okay, so let's see, what do I talk to people who, you know, look after a very important part of the body. And interestingly, actually back in HKL, where I used to work, we used to have lots of cases which we used to co-manage with the pediatric dental team there. And it gives me great honor to host this lecture, the first for pediatric neurology to pediatric dentists, and to many more coalition and alliances between the two of us. So Anna helped me by telling what could be the two important parts of neurology which might be more commonly seen in the pediatric dental practice. Of course, there's many, but I thought we will focus on the two important ones. One, cerebral palsy, and two, epilepsy. So in this lecture, for cerebral palsy, I'll take you through the types of cerebral palsy, the classification we use, a bit on the management issues, and later just focusing a bit on oral health issues which we may see in cerebral palsy and why. And for epilepsy, a bit on the definition and classification. And I'll show you some nice and nasty epilepsy syndromes, and also touch a bit on the oral health issues which we see in children with epilepsy. So Peter Rosenbaum in 2006 described cerebral palsy as a group of permanent disorder of movement and posture. So that's an important word. It's a disorder of movement and posture causing some activity limitation which is attributed to the non-progressive disturbances that occurred in the developing or infant brain. So a few keywords here: movement and posture, it's a disorder of that. And the disorder actually affects a developing brain. So it's either a fetal brain, so either the fetus or a newborn infant, and the disturbance has to be non-progressive. So it has to be a one-off injury. It can't be an ongoing injury. Then that's not cerebral palsy. So these are the important key definitions which we need to look at before calling a child CP. So hence, because of the rather strict definitions, we would exclude motor disorders due to spina bifida as CP. We would exclude degenerative brain disorder because generally they are more progressive lesions. We would exclude tumor as a cause of CP and neuromuscular diseases. We do not have comprehensive local figures, although the Malaysian neonatal team and the neonatal neurology network have been trying to get numbers, but we don't have good numbers. We estimate the numbers of a CP at about 2.2 to 5 per 1,000 live births. There was a fall in the 60s and 70s, but when the perinatal health improved, hence the number of babies having CP also increased. And this is because previously the low birth weight babies, whom most neonatologists and pediatricians wouldn't really save, are now saved because there are many other new treatment modalities which could save them. So important number here, if the baby's birth weight is less than 1.5 kilogram, about 9% of them develop CP. And if the baby's weight is a bit bigger, like at least 2.5 kilogram, just about 0.3% develop CP. So hence, when these babies graduate from the NICU, we would also tell the parents to watch out for signs of CP, and I will go through with you what are those signs. So this is a very complete list of etiology of cerebral palsy, or basically etiology of any neonatal brain injury. The damage or the injury or the insult could occur in the prenatal period, perinatal period. Perinatal period means around the time of birth, and also the postnatal period, so at least up to 28 days. So prenatal, the commonest would be hypoxic ischemic disorders and other disorders. Perinatal period, again, asphyxial diseases and also prematurity. And postnatal period, again, asphyxia, hypoxic ischemia, hyperbilirubinemia, strokes, and infection, including meningitis. So what are the common etiologies in our country? Definitely prematurity with either intraventricular hemorrhage, that is what IVH stands for, or PVL, periventricular leukomalacia, would be one of the toppers. And on the MRI you see, on the first MRI you see a really white stringy thing in the ventricle. That's the intraventricular hemorrhage. Another important cause would be neonatal HIE. So despite doing a lot more seizures now, the incidences of neonatal HIE has not reduced. Hence, we think the pathology and the pathophysiology probably predates the perinatal, it's around the perinatal period. So hence, even doing a lot more seizures doesn't really reduce HIE. So the second MRI you see, those a bit more whitish signals on the brain MRI, those are hyper intense signal, and this is a baby with a profound HIE. Other common etiologies would be a cerebral malformation. Some babies are born with either too much brain tissue or too little on one side, or too smooth. So this include a group of babies whom we lump them as cerebral malformation. Meningitis, brain infection, trauma is also a big thing, and whether it could be accidental or non-accidental. And of course, kernicterus, which means very high jaundice level, where the bilirubin actually sits down in the globus pallidus in the brain and causes neurological injury. So how would we then decide how to classify a child with CP? So one way of looking at it is to actually delineate what's the extent of the involvement. So there's a small cartoon down there where the darker orange color is the affected area. So if a child has only one limb involvement, we would call it a monoplegic CP. If half of the body is involved or weak, we would call it hemiplegic CP. If the lower limbs are affected more than the upper limbs, we would call it diplegic CP. And if all the limbs are equally affected, then we would call them quadriplegic CP. So this delineation sometimes becomes more clear as the child grows bigger, but there could be some subtle clues when they are younger. Sometimes you can have a mixture of a diplegia and a hemiplegia. So it's always important to examine the child and see where we think the extent of the involvement is. Another way of looking on how to classify them is the predominant movement, which could be the problem. So a child with CP can have predominantly spasticity, which is defined as an increase in the muscle tone, hence the muscles stiffen, or the child may have dyskinetic movement, which is essentially involuntary, erratic, twisting or writhing-like movement, or least commonly ataxic CP, which is basically the inability for these children to coordinate muscle movements, just like a clumsy kid. Sometimes these movements can coexist, but usually one predominates. So we might say spastic hemiplegic CP. So spastic is the predominant movement, hemiplegic is the extent of the weakness, and CP is the condition the child has. Sometimes we say spastic slash dyskinetic quadriplegic CP if we think both of the movements are equally important to be described. So this is how we generally describe these children. And you may wonder, why are there different types of movements which we see in CP? Now, basically, why certain children get spasticity, why certain kids get dyskinesia, why certain kids get ataxia, actually largely depends on which is the part of the brain that is injured. So if the injury is in the motor cortex, then the predominant movement disorder you're going to get is spasticity. If the injury is in the basal ganglia, then we are going to get dyskinesia. And last but not least, if the injury is mainly in the cerebellar white matter, then we would mainly get ataxia. There's a small cartoon depicting on where these areas are, roughly. In reality, most patients, as they say, don't read textbooks, and they also don't read guidelines. So they usually have mixed picture, but of course we describe the predominant picture. And remember, every child is different, as the neuronal mix is unique to him or her. So just keep this in mind. So first we will just go through on spastic cerebral palsy. So this is the commonest CP. 80% of CPs are spastic CP. They may have a bit of dystonic feature. Interestingly, in the first few months of life, some of them will have normal tone or will be very hypotonic, and they develop the increased tone a little later. So how do we pick them up if they looked pretty normal in early infant years? So we look at the persistence of primitive reflexes. There are many ways of picking them up, but this is a very well described way, which is the persistence of primitive reflexes. So every baby is born with primitive reflexes, and these primitive reflexes must disappear. They disappear at different times. So, for example, the well-known reflex, which you see the baby doing in the photo, is called the Morris reflex. You gently drop the baby, and what you see is a flexion and abduction of both the upper limbs, and it must be symmetric. However, if this reflex persists at 3 months of age, that should ring a bell to the clinician to tell you that, hey, something is not quite right. And then we examine and look for other primitive reflexes. Hence, if the primitive reflexes don't go off by the time when they should, these are red flag signs to predict which child could develop cerebral palsy. So among the types of spastic CP, first is spastic diplegia. So this is an important type because we have our neonatal ICUs are doing very well. They are very dedicated neonatologists in all these ICUs looking after the babies. So low birth weight babies are surviving. Previously, they used to die. Hence, we are going to have babies with brain injury. I would use the word brain injury because it's essentially a term which we use in neurology to describe even any injury, not necessarily has to be trauma. Okay, so in spastic diplegia, because of the vulnerability, or what we call the selective vulnerability of the preterm brain along certain areas, these areas are predominantly the one which is going to be involved. For example, the intraventricular hemorrhage and the periventricular leukomalacia. So those are the vulnerable areas where the babies would get injury. So in spastic diplegia, most of the babies would have involvement of the lower limb. This is because there is an involvement of the cortex which supply the neural fibers to the lower limbs, or there's an involvement of the pathways that supply the lower limbs. So for example, in cartoon A here, this is the area where a preterm baby might get any ischemia or hemorrhage. And these are the pathways which supply the leg. Or if a baby gets an infarct around here, then this is the area where you know is the motor cortex. So these babies will have predominantly a lower limb involvement. So if you look at the previous MRI, the injury seems to be along the pathway which supplies the lower limb. Hence, these children have mainly lower limb involvement or spasticity. So this is a video of a child. She's being studied in a gait lab. Hence, you will see a lot of sensors over her leg, and she's using an assisted device to walk. And what you can see is her feet are both tiptoed. So she has difficulty turning by her own. Her knees seem to be knocked in together. And she's standing with a crouch. So this is a classic gait of spastic diplegia. And as you can, and if you may have seen, the upper limbs were pretty okay. Next, I would go to spastic hemiplegia. So again, spastic, increase in muscle tone, make the muscle stiffen. Hemiplegia, involvement of half the body. So that's an MRI of a child with a middle cerebral artery stroke. This is the left side, this is the right side. So it's a right MCA stroke. And this would be the classical clinical scenario which would have a sequelae of spastic hemiplegia. So a stroke could happen as a congenital stroke or acquired later on in life. These kids, again, can also be asymptomatic in the first few months of life and will usually present later when the infant actually develops hand preference. Remember, no young infant should develop hand preference. That means the infant should be using both the right and left hand to reach out for objects at up to 12 months old. After 12 months old, hand preference is allowed. But anything less than that, we need to look at whether the hand which the infant is not interested in using might be weak. Hence, it's important to take this history, hand preference. The lower limb involvement sometimes won't be very obvious in the first 1-2 years, as these children usually walk maybe about 2 years old, a bit later than usual. The lower limb involvement is only a bit more obvious when they start walking. So this is a child in a playground. So you can see she can stand up from a squatting position. And there is a lack of the right hand movement. You see the left hand, she's able to lift it, anti-gravity. The right hand doesn't seem to have lots of spontaneous movement. And look at her lower limb. She doesn't really move it as much. And as she tries to walk, you see it sort of externally rotating and coming back in. So this is called a circumduction gait. So she's still able to walk, albeit not so stable, but you definitely can see, yeah, poor her, she fell. But you definitely can appreciate a sense of weakness over the right upper limb and lower limb. So this is a child with hemiplegia. The third type of spastic CP would be spastic quadriplegia, and this is the most severe form because there's involvement of all the 4 limbs, upper limb and lower limb. Sometimes you have a greater involvement of the upper limb muscles. Usually spastic quadriplegia is associated with a lot of other morbidities like bulbar palsy, fecal incontinence, mental retardation, and epilepsy. Generally, quadriplegia could be spastic with a lot of other morbidities like bulbar palsy, fecal incontinence, mental retardation, and epilepsy. Generally, quadriplegics could be spastic, plus minus dyskinetic or mixed. These children are usually fully dependent and will need care. Most of them actually do not live in their usual years, and as they develop many complications like aspiration pneumonia and multiple contractures. This is a common habitus we see in children with spastic quadriplegia. So the head might twist to one side. Their hands usually will be fisted. Their lower limbs would either be extended out, or sometimes they would crisscross, and we call this scissoring. Sometimes when they also have dystonia, their shoulders and head tend to press backwards, and their back arches up. So the next cerebral palsy. So we were done with spastic cerebral palsy. We move to the next one, dyskinetic cerebral palsy. It's also locally common because of neonatal HIE and connectorus. Two big types. One is the chorioattitoid type, where you will see involuntary writhing-like movements, and dystonic type, where you would appreciate sudden increase or change in muscle tone with contractions of both agonist and antagonist muscle, usually precipitated by emotional change or altered posture or contact with surfaces. Some patients have got both chorioattitoid and dystonia, and to complicate it, even spasticity. So there's an MRI of a child with HIE. Okay, there's a child with chorioattitoid CP. So he's sitting up. It looks quite bright. It's looking at you, but what you can see is involuntary, rather smooth, dance-like, sort of writhing-like movements of the upper limb. And at the beginning of the window, you saw it even beginning of the video, you even saw it involving his face. So this is chorea. And this is a child with dystonia. So you can see painful sort of arching-like movements. It's mainly when the child is in contact with the surface. It gets better when somebody says, relax, relax, when he gets excited. And you can see they've got a very nice muscle build. Most of children with dystonia, they look very muscular because their muscles are always moving, so always contracting. So that's dystonia. The last type of CP would be ataxic CP. This is not so common. Some people have described about 10%. I would say in my own personal practice, maybe about 5% of CPs. Maybe we are missing them because sometimes they are very mild. And these kids can just present as clumsy children. They usually present in the second year with the clinical features of ataxia. And later, they will present with even tremors and dysmetria. Most of them walk by about 2 to 3 years old. So sometimes, that sort of description which we used might be very confusing because, as you can see, a spastic hemiplegic CP, like the girl in the video, could walk. So one might think that, oh, a spastic CP would never walk. So that's why there is this thing which most neurologists use called the GMFCS classification. Some of y'all may be aware of it. So they are mainly, so there's classification according to age group, but this is a common one which we usually use. So we usually start classifying them from 2 years old. And what you notice is GMFCS level 1 would be normal kids, indoors, outdoors, they walk without any problem. They can climb the stairs independently and do not need help. In contrast to GMFCS level 2, where they usually can walk indoors and outdoors, maybe can't walk as long as GMFCS 1, and maybe they can't walk on very irregular terrain. And usually when they climb upstairs, they usually need help holding onto something. GMFCS 3, indoors, they usually need some assistive devices to walk, but they usually can walk on their own. But generally outdoors, they use a wheelchair and they self-propel. GMFCS 4, indoor, outdoor, generally they need more assisted devices and they usually can't self-propel their wheelchair. They usually need help either by someone pushing it or by a motorized sort of wheelchair. GMFCS 5 is the most severe. As you can see, indoors, outdoors, they basically ambulate with a wheelchair. Somebody needs to push them. They got very poor neck and head control, and they usually need sort of help to sort of maintain their posture of their head and neck. So sometimes we use this, not sometimes, actually quite often we use this classification because it tells us practically what a child can do. So spastic hemiplegic CP, like the girl in the video, probably GMFCS level 2. So that sort of thing describes the kid a bit better. So how do we manage children with CP? Again, MDT. MDT is very important in managing these kids. I put the dentist on top because I'm giving a talk to dentists. But essentially, I think the parents are the most important person in this whole system. I tell my parents, you are the doctor, you are the neurologist, you are the nurse, you are the physio, you are the OT, you are everything. So it's important to have a dedicated combined clinic if you can in your local setup, because these patients would need to see so many different practitioners. And sometimes they, when having a combined clinic, you ensure that all the input is sort of well looked into. So as you can see how complex these patients are and the myriad of complications they might have and the challenges in managing them, you would know that there'll be a lot of issues. There'll be issues with mobility and transfer. Children can't move as normal as normal as other kids, typically developing children. They've got problems with their visual spatial skills. They've got issues with their activity of daily living. There might be a reduction in the way they communicate and they speak with others. They can have behavioral disorders. They can have challenges in adjusting to the social peers. They can have learning disorders. They can have seizures, epilepsy, feeding and nutrition problems, major issues with GI, constipation, sleep disorders, and definitely oral health issues. We also have to look into welfare aid because managing this kind of children is not cheap. They actually, it's quite expensive looking at whatever they need. And sometimes aging parents can't look after them and these kids need to be placed in institutionalized care. So hence, it's a really long marathon in managing these children. So we may wonder why children with CP actually have oral health issues. So kids with cerebral palsy actually have got higher risks of gastroesophageal reflux disease, mainly the dystonic type of CPs, but even the spastic type. So the usual way we get a history suggestive of GERD, and if we think clinically it's GERD because it's very high incidence, we actually treat them with anti-reflux medication and also food adjustment. Children with CP, especially the most severe kinds, that means GMFCS 4, 5, and mainly the spastic dystonic type, would have sucking, swallowing incoordination. A lot of them also have drooling and also chewing difficulties. And because of a significant jaw spasticity, it'd be difficult for these parents to actually ensure good dental hygiene and oral hygiene, because it's very difficult to brush their teeth, let alone even, some of y'all may have examined these children in your setup. It's so difficult to even open the jaw. So it does definitely make sense that these kids usually have significant oral health issues. Even sometimes, even examining their teeth just to check whether they've got caries, it's not easy. So we opportunistically examine when they open their mouth. They're also prone to get oral infections because of all the drooling and all, like candidiasis. And sugar content of the multiple medication they might be on is not really helpful for the dental health. So briefly, I'll just speak on what we do as neurologists for spasticity. These kids are usually in a rehab program with a dedicated physiotherapist and an occupational therapist. Sometimes we use medications to reduce their spasticity. In cases of focal spasticity, we also inject botulinum toxin. Intrathecal baclofen is another way where we use to reduce spasticity. The hospital rehab terrace have started this for pediatric population. Other than that, not many people have actually done intrathecal baclofen. And in the past, a famous neurosurgeon used to do selective dorsal rhizotomy, but it's no longer the fashion now. Orthopedics would be another big group of people who manage these children. So lots of contractures, they correct the bony deformities and help us with the hip dislocation. These are the various orthotics and seating aids which these kids may need. Okay, so I have allotted half an hour for cerebral palsy. I will continue, Anna, with epilepsy, or should I?
Yes, you can continue.
Take questions. Okay, great. Okay, so I hope you guys are still with me. So I will speak now on epilepsy and approach and classification. So at the background is an EEG, a very bad EEG of a child with epileptic encephalopathy, which means it's one of the not so good epilepsy syndromes. So back to definitions again. So what's an epileptic seizure? So these are all from the International League Against Epilepsy. So they're all well-known definitions. So epileptic seizure is the transient occurrence of clinical manifestation of abnormal, excessive, or synchronous neuronal activity in the brain. And epilepsy is a disorder of the brain which is characterized by an enduring predisposition to generate epileptic seizures and by the neurobiologic, cognitive, psychological, and social consequence of this condition. Such a mouthful, right? So, but I like this definition, which is the operational definition. So I like to use this. So if a child has at least 2 unprovoked seizures occurring more than 24 hours apart, we would label this patient of having epilepsy. Or the child has 1 unprovoked seizure and a probability of further seizures similar to the general recurrent risks after 2 unprovoked seizures, we would call this kid epilepsy. Or even if with 1 unprovoked seizure and an abnormal EEG, I could diagnose an epilepsy syndrome, I would call this patient epilepsy. When the child presents to us with a first seizure, we would take the history. And if there are any clues suggesting abnormal MRI features or any clues to tell us that there was prior neurologic insult, for example, at birth, the child had HIE, or at birth, the child had meningitis, then these are definitely high-risk kids of getting epilepsy. So we could actually even call them having epilepsy just with 1 seizure. And now even a child has 1 seizure, we do an EEG. So if the EEG is abnormal, we could label these kids of having epilepsy. So why do we wait for 2 seizures in the setting of no EEG? We know, it's an adult study, but we generally quote this study. We know after 1 unprovoked seizure, the risk of a second seizure at about 60 months is 33%. But after a patient has 2 unprovoked seizures, the risk of the third seizure at 60 months is almost double, 73%. And this doesn't really increase much after the 3rd unprovoked seizure because the risk of the 4th unprovoked seizure would be about 76%. Hence, most of us use 2 unprovoked seizures with normal EEG and everything normal to call this child epilepsy because we know the risk of getting more seizures would be higher. So what's an epilepsy syndrome? So basically when we have epilepsy and we cluster different signs, symptoms, we could actually label them into an epilepsy syndrome. And these syndromes are actually classified based on the age of onset of their first seizure, the seizure types the kids have, whether the development is normal or not, and whether they have classical EEG abnormalities or MRI findings. And having an epilepsy syndrome is actually very, very important because we know what anti-seizure drugs would work better in certain epilepsy syndromes. And we can tell the parents what is the prognosis of your child becoming seizure-free. And this is very important information which most parents want to know. So having, what's the definition of resolved epilepsy? So hence, epilepsy is considered to be resolved. That means you're done with it. In individuals who have passed the applicable age for the epilepsy syndrome. So basically it's different for different epilepsy syndromes. And the child has remained seizure-free for the last 10 years with no seizure medications for the last 5 years. Hence, I tell my patients, okay, after stopping your medications, first year no seizure, second year no seizure, it's good signs, but we still wait until 5 years no seizure after stopping medicine to say that your epilepsy is resolved. So this is a very simple way and a very sort of a question which I think we designed ourselves to ask ourselves how to approach this patient. So when a child comes to me, the first question I would ask myself is this a seizure? Because children do a lot of funny movements. Children, infants even, even more complex. We get videos of, is this a seizure? Is this a seizure? Is this a seizure? And sometimes we don't know, but definitely taking the history. And in the era of having smartphones, video, and if we are lucky, getting an EEG would be important pathways of deciding whether it's a seizure or not. If it's a seizure, based on what we know, what is the seizure type? Is it a focal seizure? Is it a generalized seizure? And after knowing whether it's focal or generalized, we want to know what is the epilepsy type. Is it a focal epilepsy or it's a generalized epilepsy? And if you want to stretch it further, we also want to know what is the epilepsy syndrome involved. With the advent of better MRI techniques, genetic and metabolic tests, we hope to get to the cause of the epilepsy. And that would be the last diagnostic approach, which I would definitely want to know. What is the cause of the epilepsy? Because this would implicate, if it's a genetic lesion, if it's a genetic cause, then now we know certain medications work for certain genetic mutations. So it's important to know then we give the correct anti-seizure drug. So this is called precision medicine in epilepsy. And if an imaging shows an area of the brain which can be removed surgically, this could essentially cure the child's epilepsy. Hence, all this is very important. These are important questions to answer. They're very basic, they're very simple, but I think it answers the question. So in 2017, ILAE, which is the International League Against Epilepsy, ILAE, this is the latest classification of epilepsy. So seizure types are now categorized as being focal, generalized, or in sometimes we really don't know, unknown. Epilepsy types, focal generalized, combined focal generalized, or unknown, and the different epilepsy syndromes. Various etiologies which we may see would be structural etiologies, genetic, infectious conditions, metabolic disorders, immune-mediated epilepsies, and actually in a big chunk, we really don't know why these children seize. So when we look at classification of seizures, this is the basic version. So we will divide them into focal onset, generalized onset, and of course, unknown onset. In focal onset, we will decide whether the child's awareness is impaired or preserved. And then we would decide whether there is a motor onset or a non-motor onset. So the types, so it's the same for generalized onset and also for unknown onset. So for motor onset, the ways these children can present would be either having automatisms, atonia, clonic jerks, spasms, hyperkinetic movements, myoclonic, or tonic. I know these words are big, but I guess it's just for you to know that there are different types of motor onset of seizures. And sometimes it can be very subtle because a child can have a sensory seizure. just a funny sensory feeling, and these kind of seizures might be missed. A child can have emotional outbursts, a crying outburst, and this can be actually a non-motor onset of a seizure. So I'm just trying to share with you how seizures can begin. It doesn't always have to be a generalized tonic-clonic seizure, but now we call it focal to bilateral tonic-clonic. So no longer generalized tonic-clonic. So things have changed lah. Okay, so this is just an expanded version. I don't think you guys need to just remember this, but it's just FYI. So focal onset. So what's focal onset? So when a seizure actually originates within the networks limited to one hemisphere. So this is the onset, okay? It's not the whole duration of seizure. The seizure usually is discretely localized. That means it doesn't go to the other hemisphere, but sometimes it can distribute to the opposite hemisphere. But as you can see, the seizure started only on one hemisphere. So the networks of the epileptogenesis or the epileptogenic zone was limited to only one hemisphere. So this is a focal onset. Now, what about generalized onset? So we think that for generalized onset seizures, it actually originates at some point within. So it's essentially, in a way, sort of focal, but it rapidly sort of engages and bilaterally distributed networks and goes to the whole cortical system. So this can include cortical, subcortical structures in the brain. So I'm done with focal and generalized onset seizures, and this is from our Malaysian pediatric protocol of just some of the common. Just want to go through with you common epilepsy syndromes which have been described very well in the ILAE. So we as neurologists try our best to fit in a patient into any of these syndromes because it actually helps us prognosticate and treat these patients. So remember the first question, is it seizure or not? So I have been caught guarded or unguarded many times in lots of videos, which I think is a seizure. And then, when I look back and study the EEG, they are not seizures. And it's very important because we don't want to simply treat children who don't have seizures with anti-seizure drugs. So seizure mimics is a real thing. And honestly, I think they are quite common. And a lot of these children have been misdiagnosed with seizures, especially in infancy. So infants can have a lot of movements which look like seizure. They can have movements in sleep, jerks in sleep. I've had patients with sort of 3 or 4 anti-seizure drugs, but all the child has was a physiological sleep myoclonus. So history taking is very important. Sandifer's is a description of very severe reflux where the child arches, and this can be misdiagnosed as seizures. Some children have sort of shuddering attacks during feeds or during a change of diaper, and these have been commonly misdiagnosed as infantile spasm, and the list goes on and on. I will now touch on 1 or 2 benign epilepsy syndromes and 2 nasty ones. So this is a very common, very, very common epilepsy syndrome. It's called BECTS. Some people describe it as epilepsy with centrotemporal spikes. It's essentially benign, and I'm describing the typical one. So there's an atypical. If there's typical, there's going to be an atypical, but we're not going there. It's the commonest cause of childhood non-febrile illness. And it's actually, I think in my epilepsy clinic, this would be the commonest referral. Peak onset is about just before entering primary school. We mainly see it in boys. There are no antecedent risk factors. The seizures are usually brief, usually occurring in sleep. But of course, some children can present seizures even during the day and in awake state. They usually are awakened by a throaty or gurgly sort of choky noise in sleep because of the orofacial brachial distribution. And you can get hemiclonic seizure, one-sided seizure, and even sensory seizures. Sometimes these seizures generalize to the opposite side, but by the time the parents see it, they think it's a generalized seizure. But essentially, it's a focal onset seizure. So a lot of the children have few seizures. 20% of them have got recurrent seizure. So I usually treat the 20%, the one with the recurrent ones. For these kids, even if they have one seizure every 6 months, I don't treat them because generally the seizure burden is not very big. The seizures usually stop by mid-teenage years, and hence is a good prognosis seizure. EEG is diagnostic. Usually I don't do an MRI brain unless there are some concerns from the EEG. So this is a classic EEG we see in BECS, BECTS. So these are the sharp waves. And these numbers and alphabets basically tells us which side of the brain the discharges are coming from. So the even numbers are from the right hemisphere. The odd numbers are from the left hemisphere, but this is for Malaysia. In some countries, it's the opposite. So we just need to know what's done in your local institution. C is for central, F is for frontal, P is for parietal, O is for occipital. As you can see, most of the discharges are over the central region, on the left central and right central region. And you may see some here, which is over the right temporal region. Hence, it's called centrotemporal spikes. The next epilepsy syndrome is childhood absence epilepsy. Usually occurs in children in school-going age. They usually have many seizures a day, and the main seizure they get are absence seizures, which have been misdiagnosed as daydreaming. These kids basically just have brief vacant stares, blank stares, sometimes associated with eyelid blinking or oral automatisms. The EEG, again, is very classical. What we see is bilateral, synchronous, symmetrical spike waves, usually at 3 Hz. So this is a child with absence epilepsy. And she's doing the hyperventilation test, and you can see that there is an alteration of consciousness. She's got repeated eye blinking, and then she snaps out of it. So this is a classical seizure in CAE, and we call this seizure typical absence seizure. But if we were to have an EEG at that time, this is what we're going to see. These discharges are generally 3 Hz spike wave complexes. That means you're going to see 3 spike waves in 1 second, and it's usually precipitated by hyperventilation. So some of the nasty epilepsy syndromes, one which we shouldn't miss is West syndrome. The onset is usually less than a year old. It usually peaks at about 4 to 7 months old. Usually these children presents with a cluster of spasms, especially during the onset of the cluster of spasm, the development seems to stop, and even in some cases, they seem to go backwards, regression. The EEG is quite classical. We see hypsarrhythmia, basically very chaotic, disorganized backgrounds. But sometimes in very early spasms, the EEG can be normal. Hence, we really need to keep an eye on these children to make sure that the EEG doesn't become abnormal later. Etiology could be structural, idiopathic, genetic, and metabolic. More genetic now, if I may say, with the advent of whole exome sequencing, we are able to diagnose more genetic causes of West syndrome. So this is an infant, a very cute one, I must say, well-thrived, and you saw a sudden jerk of the right hand, and maybe a bit on the face, and you see he does it again. He does it again. looks a bit restless between. There it does it again. There you go. So this is the pattern which we want to see. And we call these clusters. So this is spasm, and we call these clusters of seizures, mainly the same seizure occurring many times in one event. So this is a cluster of spasm. So you can see how these can be easily missed by various practitioners. So we try to sort of educate, GPs, pediatricians, and making sure they don't miss this very important seizure. The next nasty epilepsy syndrome would be Dravet syndrome, or another name for it is severe myoclonic epilepsy of infancy. It usually presents with a mixture of febrile and afebrile seizures, usually focal and generalized onset seizures. They usually present with seizures later on at about 1 to 4 years old, and they have different seizure types. Development is usually normal, and then later it sort of slows down. EEG is usually normal, and MRI can be normal at the beginning, but later you can have some abnormalities. Generally, if we suspect Dravet syndrome, we go on and test a mutation for SCN1A, and has got a very high association, almost 70%, with SCN1A mutation. The next nasty epilepsy syndrome, and last one, I promise you, is Lennox-Gastaut syndrome, or LGS. This is a very debilitating epilepsy syndrome. Most of these children have got a very significant mental retardation and regression in learning and behavior. The seizures are quite refractory to treatment. They've got multiple types of seizures, but generally the hallmark seizures are tonic seizures in sleep. Tonic seizures are seizures where a child stiffens the whole body, the limbs, and usually it predominantly occurs in sleep. And you can have other type of seizures as well. There are many etiologies. Some are treatable, but most are not. So I will now go through an oral health issues in epilepsy during seizures. These are what some of my patients have experienced. I don't refer all of them to the dental surgeon because some of them I just I try and manage it by myself. So tongue biting, cheek biting, lip biting, in severe cases laceration of the tongue, and this would need an input definitely from the surgeons. TMJ dislocation, especially if the parents try to restrain the seizure. So I generally tell them, do not restrain the seizure. Do not put your finger in the child's mouth because they prefer to stop the seizure because they're worried about the clenching. Parents generally put a seizure in, so sometimes instead of getting tongue biting, you get the caregiver's finger being bitten, and sometimes they put a spoon in and various metals. So this can cause a lot of trauma to the oral cavity. And very significant patients even can get damage to the ligaments in the oral cavity. Chronic health issues in epilepsy would be dental caries, gingivitis, gingival hypertrophy or gingival hyperplasia in especially children who are prescribed phenytoin. Generally what we do is we also supplement them on folic acid if they need long-term phenytoin. We generally don't use phenytoin long-term, but in some patients, that's the only medication which works. Vitamin D insufficiency or deficiency can be seen in many of my patients with epilepsy, especially if they are on many anti-seizure drugs. And this can also affect the health of the teeth, xerostomia, and of course, platelet dysfunction, care during dental procedures, especially in kids who are on high dose and long-term valproate acid treatment. So with this, I thank you and I'm ready to take questions.
thank you, Sangita. I think that was really a very eye-opening presentation as well, because I think it made us think that there are a lot of things that we could also be looking out for, I think, in the future, because we do see children, you're talking about the reflexes and children of very young age. So we've got a couple of questions here. Okay, from Prof. Uma, we have, is dyskinesis and athetosis, are they the same thing?
So dyskinesia is the big word, but under dyskinesia, there is chorioathetosis and dystonia. But the big one is dyskinesia.
Okay.
So dyskinetic
And
CP includes chorioathetosis and dystonia.
okay, another question. What about infantile febrile seizures?
Okay.
Do the children with history of febrile seizures, are they classified as having epilepsy in the long term?
No. Febrile seizures will still be classified as febrile seizures. But before we used to tell these patients febrile seizures are benign, but now we know that, we used to quote 3% risk of epilepsy later. We still have to tell that, but now we think the number is more. Up to 10% of children with febrile seizures later on develop epilepsy. Epilepsy, you
Okay.
shouldn't have any fever.
Right. So the
So,
unprovoked, that's what you say, unprovoked and
correct,
yeah. Okay.
unprovoked.
So 10%, that's quite high actually, right?
I think the latest numbers are going to be 10%. It used to be 3%. But now we know from lots of studies. I just heard another new study coming out from Duke, and this febrile seizures are actually not as benign as we think they are in at least in 10% of them.
Okay. All right. Another question here. In CP patients, how do you prescribe the medication? So I think, for example, they're asking for Botox. Which type of CP would you give Botox?
Okay, so for Botox, we usually don't give them when they are very young. We only usually wait when they are at least 18 months old. So that's the first thing, is the age. Number two, we want to ask ourselves how this Botox is going to help the patient, because when you answer that question, you know exactly which muscle to focus on. For example, if the child has got spastic hemiplegia and limitation in opening the hands, then your question would be, I want to improve the hand opening. So I want to inject the small muscle of the hand. Or just say you want to improve the pronation and supination, then you focus on the pronators and the supinators, because there's also a ceiling dose for the Botox. So we need to focus on which muscle.
Okay. Um, Still
It's a
on Botox. So
IM injection. It's a IM injection.
okay. Still on Botox, Dr. Ilham is
Sure.
asking whether you would use it for severe bruxism in your patients.
Yeah, so usually I've never had to use it so far. So far I've never had to use it. We used to inject Botox for patients with drooling. We used to inject them in the submandibular gland. But our experience with it was, I mean, we didn't get good outcome. So hence now what we do for children with drooling is we give them the scopolamine patch, and that seems to work, because with Botox you need to do it repeatedly. And then with kids,
Yes.
sedation, and we need to hit the gland. It's very tedious. So that's the only time where we ever use Botox close to the oral. Yeah, for bruxism, so far in pediatric we've not used, but I'm sure my adult colleagues have used.
Okay, another one, probably the last one. This is from Dr. Azwin. She says she has a patient with idiopathic generalized epilepsy, was on phenytoin, and then changed to lamotrigine. She then developed gingival hypertrophy. So is it due to the change in the drug? Or?
Yeah, I think the phenytoin. So generally, we don't give phenytoin for IgE. But if it's a long-term phenytoin, then yeah, usually for months or years, then they get gingival hypertrophy. Lamotrigine, I don't think really causes. I need to check. But generally, the drug of choice, if it's a non, I mean, usually we use epilim, but of course, it depends on the age of the patient. And if, now girls, a childbearing age, then we go for lamotrigine first.
Okay.
Yeah, but I think it's probably due to the phenytoin.
All right. Thank you so much, Dr. Sangita. It was such a good session, and it was a full session that somewhere in between I got kicked out, and I prayed very hard and managed to get back in. So,
Oh no.
yeah, but anyway, I think what we will do is, because since there was a cap, there's a limitation of 100 participants. We will be sharing the recorded version of this lecture, which I think many
Sure.
people are looking forward to. Thank you so much, and I think
Thank
it's been
you.
great because this year we are getting a lot of our pediatric friends to come in, and I think it's just amazing. And thank you so much, Dr. Sangita,
Thank you for
and
having
we
me.
hope to invite you again sometime soon.
Please do. Please do. I'll be delighted.
Okay. All right. For the rest of
Bye.
you, for the participants, please fill up the attendance form, and we will see you soon at our next webinar, which is in 2 weeks. Bye.
Bye.
Tastes like strawberries on a summer evening, and it sounds like a song.